Ask folks to have their attention for just a second. So I hope you enjoyed lunch. Thanks, Lucy, for the tacos. Those are great. I'm going to talk to you for a second about the new family inclusion standards, but before we did that, I wanted to call attention to the fact that someone very special to our organization is retiring this year. So Dr. Gordon Hodes, Dr. Hodes, can you hear us? Okay, I just wanted to make sure. Gave us the happy for him news, but the sad for us news that he's going to be retiring this year. So I think this may be your last PPLC meeting from what you said to us, which makes, again, us very sad, but also always invited, always invited. So with that, I just wanted to just have us play a quick video in celebration of him, and then we'll have a moment to celebrate Gordon. So, Gordon, I wanted to, if you want to say more, I was going to bring you the microphone. I want to thank everybody for letting Dr. Hodes know how much that he has meant to them, but we wanted to present you with this clock. It says, in the celebration of your decades of dedication and service to the children and families of Pennsylvania, with deepest appreciation, the PPLC. Thank you. So much.
I'll just say that, you know, you hope to make contributions, but the one thing that you can bring to the table and that I think I have brought to the table is passion, and I'll continue to have that passion.
Thank you, Dr. Hodes. If you have time to express your own celebration of Dr. Hodes, please do that. We will still be seeing him around for a few more months, hopefully. And as Ken said, we're always here. I've so enjoyed getting to know you and hearing your words of wisdom, and I appreciate you being an ever-presence in our lives, so thank you so much. And thanks, Kiana, for helping us put together that beautiful video. So we'll have a copy of that. And Dr. Hodes, you'll have a copy of that. Lucy will send you a copy of that. You're welcome. Should be able to help it together. Yeah. Okay, thank you so much. Okay, so very quickly, before we get started, we are going to just briefly talk about the family inclusion standards. Laura Simmons, who's our family inclusion manager, she is dealing with a bit of a throat issue, so she is not with us, and she can't really talk right now, so I'm going to just do a quick overview of what the family standards are, and then we'll probably talk a little bit more about those in the near future. So, Lucy, would you mind just... Oh, look at that. It's magic. Okay. So for those of you who may be aware, the PPLC and FTAC, which is the Family Training Advocacy Center where the PPLC lives, we have been working on a concept called family inclusion and the family inclusion standards for many years. We had an initial version of this document probably in the early 2000s. The second version of the document happened a few years ago, and when Laura came on, what we talked about was how we could update the family inclusion standards to really be thinking about how family inclusion works across the lifespan. So for those of you who may not know FTAC, Family Training and Advocacy Center, we really developed standards to support families of adult members who have mental illness. So frequently when you think about family members, you're thinking about family and children, very important, but we were really charged with supporting families who are supporting individuals who are adults. But we also know that as you get older, you also need family, and family looks different throughout the lifespan. So it really does seem like family support is changing in the language and in the approach. So that's why we formulated the family inclusion standards across the lifespan. Laura did a wonderful job reaching out to folks, putting together old documents, reaching out to other experts in the field, and did a really nice job putting this document together. So very quickly, if you can just scroll down a little bit, Lucy, I'm just going to go over it very quickly. So there's a long introduction, and this is actually the short form version, and we'll probably be doing a presentation on this at some point in the near future. But I just wanted to put this on everyone's radar because you'll all get a copy of it, and we're going to start to be putting together toolkits and trainings around this topic. So if folks are interested in getting involved in the family inclusion space, Laura would be your contact on that, and we can certainly reach out and talk about how to get you more connected. Would you mind going to the next page? Oh, there you go. So we have several standards. So the first one is engaging family members in treatment and services. That's where you start. And then it goes all the way down through sort of the role of family, how to provide general support and guidance to families, how to educate families, fostering a family-centered environment, collaborating with other providers in care, transition planning, and one more. We could go on the next page. Yep. Advocacy and opportunities for family leadership and staff training and supervision. Something she also put together, which I really appreciated, was some of these special considerations. So what we were looking at with this document was a very generalized document that was really covering what family needs are in any basic service that you would have across the lifespan. But she really does dig into some of these other special considerations of populations where you really need to be thinking about, individuals with disabilities, geriatric and older adults, minorities of Pennsylvanians, refugee and immigrant families, substance use and recovery, children and adolescents, LGBTQ plus community, and also justice-involved individuals. So that's not an extensive list, but it's just where we were hearing a lot of comments about what about the population that I'm working with, what do we do, you know, if someone's justice related, how does family inclusion look differently in those systems? So this is just a little snack of what's to come, but I wanted to give you a chance to see what was coming out of FRN, and I'm sure Laura says hi. We've been texting, so I'm sure she says hello when she can say hello again. So if you have any questions, if you could please reach out to her. Her email is Laura Simmons, which is L Simmons, not Laura Simmons, it's L Simmons at pmhcc.org, or you can certainly shoot Lucy an email or myself an email if you'd like to get more involved in the family inclusion work. So thank you very much. Okay. Thanks, Mary. All right, so we are moving on in our program, and I'm very happy to introduce Dr. Julie Graziani, who is here with us today. She is the medical director at OMHSAS. And Deputy Secretary Smith was going to be joining us, but I believe she's dealing with a family need today. So it's going to be Julie, and we're very happy to have you here with us. You can sit here or there, wherever you want to sit, whatever you want to do. Whatever works for you. Sure, that works. All right, so we'll drop you off at the table, and yeah, it's your table. There you go. All right, well, thank you very much, Dr. Julie Graziani.
Now? Okay. So yes, Deputy Secretary Smith was going to join me, but she has a sick child, as we all know, that can interrupt plans. So I am going to be pinch hitting for her. Our plan was to tag team updates from OMHSAS and then also open up a conversation about a topic that has been coming across our radar more, AI and mental health care, to kind of get some of your thoughts about it. But before I start with our updates, I just want to thank you all for the invitation to come here and provide you these updates, and also thank you for convening this topic of community. I love the idea of community, and it really strikes me that we're all a part of multiple communities. And so I get this, I feel like I always just talk about my visual ideas to this group, but I see like these intersecting Venn diagrams, right? We're all part of multiple communities, and those communities very much intersect. And I think it's like where those intersections are, where the strength of us being able to move forward as a more larger community really lies. And so I'm really appreciative of this group here for highlighting that for us. I also think, as many of you know, I'm pretty new to OMHSAS. I'm 6 months into the role. And so I am very fortunate that I have this position where I have this eagle eye view of the different communities that really care about mental health and mental health care. And one of the questions that I ask myself in this role every day is kind of how can I foster those connections between the communities? And in thinking about that, and in thinking about having very recently kind of been more in the trenches of the mental health care space, working as an inpatient psychiatrist, I came to the updates, topic as like, what would I want to know from OMHSAS? What are you doing, OMHSAS, right? That impacts me as a provider. And so that's where Jen and I were coming from. So I have both paper and also electronic. So please excuse me for when I'm looking at my notes. And also, I'm going to ask for apology ahead of time in the sense that I am only 6 months in, so I do encourage questions, but I may not know the answers, but I promise to get them to the people who have a better shot at answering them. So, first updates. What everyone, I'm sure, is really curious is what are the updates about the changes stemming from HR 1? And so one of the things I think everyone as a provider wants to know is like, what can we do? What can we tell our patients? What can we tell our clients? And so when talking about the changes with patients, it's really important to remind them to make sure their contact information is up to date. And there's different contact information. So We would ask that you encourage your patients and your clients to update their address with the Department of Human Services. So logging into Compass, so COMPASS, dhs.pa.gov/compass, or there's also a My Compass Pennsylvania mobile app to check and update your address. So this way the department can have easy communication with those individuals. Also reminding them to report changes of their address to the U.S. Postal Service. I know that's kind of annoying, but it's really important when we're thinking about all kind of the federal and the state communications. And then they can also sign up for texts and emails from DHS. So if they visit dhs.pa.gov/text to sign up for the texts and emails, they'll get even faster notifications about their benefits. There's also a Human Services Helpers Substack, where they can get updates, resources, newsletters, and more that can help Pennsylvanians access services and support, navigate change, and live healthier lives. So you can get the link to that by going to the dhs.pa.gov website and searching for the Federal Cuts website. There's a lot on there. And then in addition to that, a stakeholder work group was formed to include Medicaid recipients, advocates, providers, legislators, and others. The purpose of that work group is to share information and gather feedback. And the first meeting was mostly an informational push from the Department of Human Services, and it can be found online. So if you go to the DHS website, you can get that. So those are the HR1 updates. So if you take anything away from there, it's really making sure that your patients and your clients can be communicated with easily. The next update we wanted to provide all of you is we are furiously working on some deliverables related to the SR settlement that was settled a few months ago. OMHSAS recently onboarded Bobby Cagle and a team comprised of data experts from Chapin Hall. They're behavioral health and county family Medicaid experts, and also people with county and state government experience. So we are working through a number of deliverables, such as data sets required for benchmarking, guidance on screenings and evaluations, the complex needs planning process, and bulletin updates. And you may have seen that there was a new bulletin that came out about our complex needs planning that is also available on the DHS website. And the complex needs team will be doing trainings about how the new process is working. But that is really a group of folks really dedicated to individuals with a multitude of challenging and complex needs. So they really are great advocates for those individuals. Regulations, another exciting thing we do at OMHSAS. We have a number of regulations kind of in the flow. So in no particular order, the psychiatric, residential, and treatment facilities, so the PRTF regulations that you have been hearing about. The purpose of those regulations is to codify minimum licensing standards for children, youth, and young adults receiving services in psychiatric residential treatment facilities. A lot of people want to know what the status is on those, and so DHS has updated the regulations based on feedback received during the public comment period, and the final form regulations are currently rooting through the approval process. There was great consideration given to requests for additional flexibility due to financial strain and implementation timelines. So more to come on that, but we did hear you on that. The 5100 confidentiality regulations. The purpose of those regulations is to update Title 55, Chapter 5100 to align with the Pennsylvania Act 32 of 2022 and HIPAA requirements. The status of that is DHS is reviewing those few comments that were received, making edits as needed, and will be submitting final form regulations in coming months. And then finally, the crisis regulations. So the purpose of the crisis regulations are to codify minimum licensing and payment standards for behavioral health crisis intervention services. Those were recently out for public comment, and we received over 900 comments on those, which is really, I think, wonderful. I think it's really great that that this community has kind of read those, put their input in, because again, it's crisis regulations for the community, right? We come back to that word. And so we want to make sure that they are working and that they are accessible and practical. So our Bureau of Policy has been furiously working through all of those comments, and they are incorporating edits kind of as we speak, and will be planning follow-up meetings over the coming months where appropriate. Also, there was a question about payment. DHS is routing internally for review and expects this to be complete within the next couple of weeks. I think that has to do with the payment portion of the regulations. All right. So those were the things that Jen was going to update you on. Moving along kind of at a quick pace. So this gets to the idea of kind of what does OMHSAS do that maybe the community might want to know more about. The first thing that came to my mind was that OMHSAS actually has performance improvement plans that they set out for the county and the behavioral health managed care organizations. I admit, I did not know this up until I joined OMHSAS. And so these performance improvement plans are really important when we think about population health and population health on a community mental health level. So our current performance improvement plan just started this year. The topic is improving suicide prevention and community resiliency. You know, unfortunately, one person dies by suicide every 5 hours in Pennsylvania, and that was based on 2021 data. So that is, you know, one person is already way too much. If you have one person every 5 hours, having this happen to, you know, that is certainly a crisis, and I think we certainly see that. And so really a suicide prevention approach is needed, and it's going to, not that we're not already doing that, right? But I think we want to identify that this is a problem, and we want to be strategic in how we approach that problem. And so OMHSAS set out on this performance improvement plan with their primary contractors, which are, for those of you who don't know, kind of counties or county joinders, and the behavioral health MCOs. And we really wanted to make sure that these prevention plans included both screening and assessment. And the aim is to develop a comprehensive public health approach that addresses upstream social determinants of health implicated in suicide risk, as well as promotes early identification of risk factors, assessment, and then also evidence-based interventions for those at risk. The plans are meant to focus on suicide prevention, depression screening, and health equity, because we also understand that there are certain populations in Pennsylvania who are at higher risk of suicide, and we want to be able to meet those unique needs of Pennsylvanians. You know, so we think about veterans, those folks in the farming and agricultural community, the LGBTQ plus community, youth with a special emphasis on Black youth. I think someone had talked about the Black Youth Suicide Prevention Grant. I imagine you probably work with Dr. Perry Rosen on that, who, you know, she is kind of our suicide prevention expert at OMHSAS, and she is really wonderful. And so we really, you know, there's so much that's happening. I think it's really important that this community at large be aware of what's happening so we can kind of focus on those intersections. And so in creating this performance improvement plan, we asked our behavioral health MCOs to develop plans that would lead to the following outcomes. And they include increased percentage of their members who have completed suicide screens, suicide risk assessments and care plans, improved rates of follow-up visits after the ED visit or hospitalization for mental illness or intentional self-harm. This is why I think as a provider, there's always this like, is there a follow-up within 7 days? Is there a follow-up within 30 days? And at times it can feel so checklisty, but I think when you're, again, in that kind of like eagle eye position, it's like, oh, because we want to make sure that like the community is doing their thing, right? We want to make sure we're getting these performance outcomes that we know are going to help mitigate the risk that we know is there after someone is discharged from the hospital or after someone is discharged from the emergency room. And then we also asked them to include in their plans outcomes that would improve rates of depression screening and follow-up, and then addressing a social determinant of health. And then I think if you just kind of put the PIP aside, right, our performance improvement plan aside, for context, the state of Pennsylvania also has a suicide prevention plan, right? So again, we see these problem areas and we're working on them with different lenses. So it's important that we're all aware of what those solutions are that are being worked on. And so the Pennsylvania Suicide Prevention Plan has 3 shared goals. One is improving access to and use of suicide data, including and especially for those populations at risk. 2 is improving partnerships between the state agencies and other entities engaged in suicide prevention efforts at the state and local levels. And the 3rd is increasing efforts to collaborate around suicide risk and protective factors as part of upstream suicide prevention. And since we're talking about, I just gave you kind of our PIP suicide prevention and community resiliency update. And that kind of leads me into just kind of highlighting the really great work that 988 is doing. I think in OMHSAS in Pennsylvania, we really want to build out the continuum of crisis care, and that really starts at 988, right? Someone to call. So just to highlight what has been happening in the last year. So between December 2024 and November 2025, we received 151,864 calls. So that is a lot. And to give you something to compare it to, in calendar year 2024, there were 118,383 calls received. So that's an increase of 30,000 calls. Also, with those 151,000 calls, we had a 91% state answer rate. So we really aim for a 90% answer rate. And then what happens is if it's not answered in state, it gets kicked up to kind of the national backup line. Also with that 91% number, I think it's important to emphasize, it doesn't mean that 9% is getting kicked back up. We usually have an average of about 8% call drop, or it's not a call drop, it's called an abandoned line. So someone calls and then they decide to not continue with the phone call. So the fact that we're above 90% is really excellent. In February 2026 alone, there were 15,237 calls that originated in state. And we had an answer rate of about 89.6% with an average talk time of 12 and a half minutes. I think it's kind of nice to have some concrete, like what happened? Like how long does a 988 phone call last? Like what do they do? And we also had 5,395 chat or texts originating in state. That is an area where I think we are looking to kind of expand our services. Our chat and text in-state answer rate is certainly not as high as we want it to be, but I think that's something that we're hoping to really develop, especially as we head into the next topic, which is the Rural Health Transformation Plan. I'm sure a lot of you have heard about that. If you have not read our plan, it is available on the DHS website, just RHTP Pennsylvania, and you'll find it. It's very extensive. But it's really informative. And I also would encourage you all to watch the webinar from March 31st. It kind of lays out the initiatives over the next 5 years and what they're really going to focus on in the first year of funding. And really, the Rural Health Transformation Plan is a balance of statewide coordination and regional leadership and collaboration. And that regional leadership and collaboration is really important. And so kind of how the state is working is there are these PREPs, or partnerships for regional economic performance, that have been convening regional stakeholders to then create rural care collaboratives, which will help to align the initiatives with regional economic planning and development. What's really exciting, I think, at least from an OMHSAS perspective, is that behavioral health is one of the RHTP's initiatives. The other main initiatives include technology and infrastructure, like technological infrastructure, workforce, maternal health, aging and access, and EMS and transportation. So I think the fact that behavioral health is kind of highlighted specifically is really wonderful. And then you'll also see kind of behavioral health kind of like make its way into the technology and infrastructure, into the workforce, a little bit into the maternal health as well. So there's definitely this identification of the behavioral health need and the behavioral health need in rural areas in Pennsylvania. We just talked about 988. 988 expansion and education is a year one project for our rural health transformation plan. So grant funded outreach and advertising will primarily focus on rural counties and rural serving organizations, which again is really important when we think about the agricultural community and some of those other communities that have those unique needs. The other large part of the behavioral health initiative in the rural health transformation plan is the remote behavioral health consultation. And so that is kind of looking at how we are currently doing TIPS. So for those of you who are unaware, TIPS is the telephonic oh my gosh, I just forgot what it stands for. That's embarrassing. It's the telephonic psychiatric consultation service. I don't remember what the I stands for, so I apologize. But there are two main TIPS lines. One is for children who are on Medicaid CHIP funding, and the other one is for women who are pregnant or in that first year postpartum, right? These are two really important populations that I think we see some of our primary care colleagues sometimes struggling with. And we also know that it's hard to get into a psychiatrist, let alone a psychiatrist that has a specialty in child adolescent or that feels comfortable treating pregnant women. And so these TIPS lines have been established for that kind of immediate consultation need. And so the Rural Health Transformation Plan is going to look at those TIPS lines and look and see how can we expand that even further. And the other part of the remote behavioral health consultation portion is increasing collaborative care models. I think, when we think about workforce and access, the collaborative care model is a really great way to help decrease some of those waits, help decrease or mitigate some of the access issues. And so the Rural Health Transformation Plan has money devoted to it to increase those models in rural areas. And then there's also educational awards for peer and recovery specialists. There's plans for a statewide bridge clinic for substance use disorders. And they're also going to be expanding the mental health training management system, or OMHSAS. I'm not sure how many of you are familiar with OMHSAS, but it's a great, I was not familiar with it. It's a great website. And they have all of these free mental health trainings. The idea also is that there will be the trainings for individuals working in the crisis space. So it will meet kind of all of those requirements that are in the crisis regulations, but it's really a wealth of resources. So I'm coming from academic medicine. I'm always very excited when education is highlighted. So the Rural Health Transformation Plan will help to expand that. All right, so that's that. And now state hospital updates. So I think we talked a little bit last time when I was here about how our hope and our plan is to continue modernizing and standardizing our state hospital system. We have 6 state hospitals across Pennsylvania and 1 nursing home, right? And all together, we care for about 1,500 patients. And when we look at the state hospitals, they function very differently from one another, which is a good thing, but can also cause some problems as well when we're functioning as islands when really we're all one system. And so we're continuing to look at ways to standardize those, including looking at staffing and provider levels. And one of the new developments that I think we're pretty excited about is we have a new position in OMHSAS, Chief Executive Officer of Logistics and Patient Flow. And what that's the person who's in that position now, again, it's a new position, is Jessica Keith. She had been the CEO at Norristown, and now she's in this position. But when we think about our state hospital system, I don't think anyone, well, I won't say that, but there's a log jam at the state hospital. I will say that. Anyone who practices psychiatry knows that it's very hard to get someone into the state hospital system. And part of that reason is because it's also hard to get individuals discharged from the state hospital system, right? There's an inlet and there's an outlet. And if you don't have someone helping to facilitate both ends of that on a statewide system, you're going to get a logjam. And so our hope is to really help facilitate that flow for a lot of reasons. But one of the biggest reasons is you should be in the appropriate level of care at the appropriate level of time. And so having to wait months to get into a state hospital is not something that we want to happen. And we also realize that sometimes the individuals that are coming to our state hospital system bring with them a multitude of complex needs, right? So it's not I'm going to say kind of an easy presentation in the sense that, oh, they just need to be in the hospital and have a little bit more time on the antipsychotic medication. It's what are all of these additional services that we want to include while they're here with us, but also that we need to make sure are going to be there when this individual leaves the hospital and goes back to the community. And I think we've also talked about that sometimes, things can feel very siloed, right? And with mental health, it's never just mental health, right? Maybe there's substance use, maybe there's a developmental disability, maybe there's autism, and we really need to be collaborating with our colleagues. And so the individual in this position is going to kind of start those conversations a lot earlier, sometimes even before the individual enters our state hospital, and be involved in those conversations around discharge way before the individual is kind of even ready for discharge, because it takes time to set things up in the community for folks. So that's pretty exciting for us. So Jessica will be overseeing kind of patient flow and really working across the state. So kind of taking the state level view of how can we meet the needs of some of these complex folks. And then the last thing I just wanted to highlight, and I had emailed Val about this because I was so excited, but the Department of Health has a Pennsylvania primary care loan repayment program that just came out. And the reason that I was so excited was because psychiatry is included as primary care. So yeah, I heard a wow back there. And really kudos to Val, because she told me that PPLC was really involved, as kudos to PPLC, in advocating for psychiatry to be included. So if that is something that sounds of interest to you, you need to move fast because they're accepting applications until May 4th. So you got 2 weeks. But it's really for a host of positions that would qualify. So you have physicians, certified registered nurse practitioners, physician assistants, licensed clinical social workers, licensed professional counselors, licensed marriage and family therapists, and psychologists. So again, really exciting that psychiatry and mental health is included in that. So it provides repayment opportunities or loan repayment opportunities as an incentive to recruit and retain primary care practitioners willing to serve underserved Pennsylvania residents and to make a commitment to practicing in federally designated health professional shortage areas, or HPSAs. So you can just Google the DOH and the primary care loan repayment to find out more information about that and more information about the application. So those were all of my state level updates. I'm happy to take questions now, or I'm also happy to enter into the discussion that we were hoping to have with you about AI. Okay.
This is not about AI.
Okay.
So we can, I guess, ask other questions and then move on to AI. I wanted to ask about, even though there's likely not a lot that OMHSAS can do, but what I wanted to flag is the lack of recourse when the county-level mental health and intellectual disability boards are not being operated in the way that arguably they should be or were intended to be operated per statute. And there does not appear to be any clear appeals mechanism to OMHSAS, which ostensibly does have a role, right, overseeing kind of the county level structures. And I would maybe say beyond that, because that is one potential mechanism whereby public governance can actually happen at a county level. There's not much beyond that. So if you're in a county where there's really very minimal investment in true public governance, accountability, transparency, community engagement, you as a concerned resident of the county seemingly have very few options for how you can kind of bring about more accountability, more transparency, or make change happen in your community. So I'm just kind of wondering whether, A, there is something direct to do when you feel that least an interpretation of statute is being violated. And beyond that, what your thoughts are on how folks at the county level can really have more of an impact.
Yeah, those are great questions. Again, 6 months in, so I'm still learning the whole system. But my first inclination would be to probably reach out to the OMHSAS field office, who tends to have a better idea of what's kind of going on in the provider level, and then also just to reach out to OMHSAS as well. But again, that is me 6 months in, and so I will also talk to Deputy Secretary Smith to see what else is there and like who in OMHSAS should you be reaching out to.
Yeah, I mean, on the website, unless this has recently changed, emails are almost unobtainable, right?
Okay.
They're not listed of the vast majority
Okay.
of OMHSAS staff.
Yeah.
If you send emails to the generic line, I at least have never gotten a response to
Okay.
any of them.
Yeah.
So I do think, yeah, like a kind of a clear conduit for where one, like a submission email, something like
Yeah.
that would help. But also it's not easy to figure out or to even find people's email addresses. I think the field offices, at least in some parts of the state, have quite a reputation for how unresponsive they are. Okay. Part of that is those offices feeling that they just have no say, have no authority either. But again, one can just run into a lot of frustrating dead ends. I would also add, just on that, because we're now on the note of kind of OMHSAS, there's also very few, other than the Planning Council, there is no ways that I have yet discovered of really getting involved in a meaningful way. There are various state level work groups and committees that it seems like you just have to know somebody who chairs them to actually get on. And I just wanted to flag that because I guess ideally there would be more clear public listing and transparent mechanisms whereby people who really want to get involved and influence state policy can get involved. So I will say that I have been in Pennsylvania now for 5 years. I'm a tenured associate professor at Pitt, also a person with lived experience and family member with tremendous expertise and background in these topics. Every attempt I have made to join an OMHSAS committee has been unsuccessful, and I would, kind of think that there should be ways that those of us who are deeply, deeply invested in these issues can, in fact, get involved without sort of just arbitrary, only if you know the right person can you get on kind of stuff. But thank you.
Yeah, no, thank you for sharing all of that.
I'm just going to second your concern on that, actually. I think this has been a challenge that we've been having sort of with the state in general. It's not just an OMHSAS issue. This is sort of a DHS-wide concern that I think a lot of us are having. So I've, found the current OMHSAS administration to be very welcoming, very open to feedback, and I appreciate that. And if there is anything that we can be doing to make sure that people know about the Mental Health Planning Council or how they can get involved, I think that can go a long way. We spend a tremendous amount of time in a lot of our meetings, especially for working with students or other workers in the system, to educate them on what OMHSAS is and things like the Mental Health Planning Council. So, to Dr. Jones's point, having that more readily accessible, I think would be really, really helpful in helping people know where to sort of channel and get involved.
Yeah,
So,
absolutely. I think communication is so important on this. So I really appreciate you bringing that up.
nope. Okay, I'll come back. Oh, online question.
Okay, so online from Dr. Kim Fitton, she said, you stated the PRTF regulations are in the approval stage. How long do you anticipate this stage will take? And are there other steps before release?
I'm like, Gordon. Gordon, do you have any thoughts about how long it will take? I don't know how long it will take. I think someone more seasoned in OMHSAS may have a better idea of how long it takes after this. I think they would not be ready to come out at the earliest. I think it would be like May 2027 is what I had heard. But that would be the earliest.
Julie, thank you for coming and talking with us and being where you are. It is really, it's just a breath of fresh air to be able to engage with you in OMHSAS. There's a lot of things I could ask about, but I'm gonna try to keep a little focus. One of them is you started off, or it was one of the initial things you started talking about in terms of the suicide prevention activities. Mm-hmm. And you mentioned that OMHSAS has a plan, which they're now working with the managed care organizations. So that's a particular plan that obviously is targeting Medicaid recipients, right?
Yeah.
And then you mentioned that there's a suicide plan for the state. Mm-hmm. And I tried to figure out, okay, who's directing the suicide plan for the state, the suicide prevention plan for the state? Where does that come out of? And maybe that's a question I can. Where does that sit? Who is overseeing the suicide plan for the state?
I don't want to give the wrong answer, but I can tell you that all of the different state agencies are involved, and one of the co-chairs is in OMHSAS. So I don't know like where, and I apologize that I don't know that information. But I don't want to give the wrong. Do you have a yes? I think I might know. Go for it.
Sorry, here.
Right there. Okay. In 2019, we participated in listening sessions all over the state for suicide prevention, mm-hmm. and they gathered all that information, and then they wrote the suicide prevention plan for Pennsylvania. Yep. The governor, it was the governor's plan, and then but it did involve, like, we would go to a listening session, and we would have people from aging there, secretary from the aging department, secretary from the agriculture, secretary from the, we used to have service folks there, armed services, mm-hmm. veterans. And that was like, we did, I think, 9 of them, all over the state. But the whole point was to develop this suicide prevention plan. And then they I want to say, walked it around for a while, like it presented it and everything. But I've not heard anything about it being updated or anything like that.
Yeah, I think it was just the new plan either just came out or is coming out, and it's another 3-year plan. I'm not sure if it's been officially published or not, but I know in 2019, I think Governor Wolf is the one that convened it. And so I want to say that it's still kind of like rests in the governor's area, but I don't know that definitively. All the different agencies are involved. Yeah.
Right. Well, I guess the reason I ask this is because unless there's actually a person or persons or a specific office, it's a very diffuse mm-hmm. concept. And, you know, we run into an issue that I think we continue to face. For example, you mentioned that this is going to work with CCBA, with the managed care organizations, mm-hmm. right? Well, that's the behavioral health managed care organizations. Right. And there's no doubt that people who are on Medicaid, who are in managed care organizations, are clients of managed care organizations. are at risk for suicide. But there's a whole lot of other people in the state and in primary
Yeah.
health settings who are at risk for stuff. And I kind of would like to feel like the mental health system was actually extending itself beyond just the mental health system that it is directly connected to. Primary health services, whole person primary health services, collaborative care as an example, would get to a much larger number of people. And actually the evidence is that many people who commit suicide, actually the most recent visit that they've had with anybody who's a health-related person is their primary health provider.
Yeah.
So if you really want to get to those folks, it would be really helpful to be making sure that that's going on across the state, that we're actually doing screenings in primary health settings,
Yeah.
and that we are actually developing whole person primary health services with collaborative care. But I don't hear that. I hear more the siloing still.
Yeah.
And the sort of like this, we'll each do our little tiny piece, and maybe it adds up a little bit, but it doesn't actually make a suicide plan. And I just want to give a tiny piece of history to this, because suicide as an issue, as a public health issue, is not owned by anybody in the state. I got a phone call once from people in Allentown when I was working in Pittsburgh, because they were having a problem with an increased rate of suicide in Allentown. And I said, well, why'd you call me? I was running a program that was trying to bring public health into psychiatry. And they said, well, I called you because we called the state, and the state said, Office of Mental Health Service, suicide's not our problem if they're not our patients.
Oh,
If they're not our
That's
patients,
terrible.
we're not interested. This is a long time ago.
okay. Good. Bad, but better.
A long time ago. But no, suicide's not our problem. We don't actually own suicide. We own suicide if it's a state hospital patient or maybe somebody with the managed care companies. But otherwise, no, not our issue. And then they called the Department of Health. The Department of Health said, that's suicide. That's a behavioral health problem.
Yeah.
So part of the challenge, I think, is that we haven't really located suicide as a behavioral health problem or concern that needs to have somebody actually own it.
Yeah.
Really say we're going to do something about it. It's nice that the governor says he's going to do something about it. This particular governor has not done very much around mental health. It's not been something he's engaged in. The whole rural health initiative is not coming out of the governor's office. That's coming from, that's a sop to the cuts in Medicaid that are coming. It would be nice to have some place actually take this particular role on, and also to take a broader public health approach to mental health than is currently happened at the state level. And I don't know how to get there. And the last thing I'll say is that the whole workforce issue and the identification of shortage areas and the idea that we will have some loan repayment capacity is driven by whether or not there is a shortage area that's identified. The shortage areas are identified only if a region decides to go for having it identified. So the people in a region have to do the work of getting the place identified. And that is very difficult work to do. And the places that don't have those kinds of resources, which are the places that need the resources the most, have the hardest time putting these things together. And the Office of Mental Health and Services and Substance Abuse has zero role in making those designations or pursuing those designations. So it would be really helpful to try to figure out how to get a more focused approach to mental health that brings the Department of Health and OMHSAS together a little bit more around these issues. Suicide might be a good place to start. The workforce would be another one, so we can actually build this up a little bit more. So I realize you're just new there, but maybe you can make this all happen next 6 months.
But I do appreciate those comments. And I think I should apologize. My role in highlighting the performance improvement project was not to just say, like, that's the only thing that we're doing, right? Because I think, yes, we certainly have our Medicaid population that we are kind of primarily responsible for, but I do really believe that OMHSAS does think about the mental health of all Pennsylvanians, and we're not just siloed into what's good for the Medicaid population. And I also think With suicide in particular, I think part of the reasoning behind us building out our crisis continuum is that is going to be a really important part of that plan. And I hear you, Ken, when you're like, nobody owns suicide. In a sense, it's also it's in the community, right? We all have to own it, right? And so we all need to take some responsibility for it. But I certainly hear you that it is helpful when there's a large problem to have someone spearheading an initiative like that. So, yes.
Thank you so much for taking this job. It hurt me to see you leave the practice of community psychiatry, since we need community psychiatrists so much. But having someone in OMHSAS with your level of experience, current and aware, is just, well, there's no price that can be attached to it. So thanks for doing
Lloyd.
that. So now I have a complaint.
Okay. Now that he's buttered me up. No.
Shocker. That's right. In 2012, under a governor that I now call One-Term Tom, we used to have meetings where people got together for the Mental Health Planning Council every quarter. And One-Term Tom said that we really couldn't afford that anymore. Now, that's the same governor that took a $4.5 billion tax cut and gave it to Shell after Shell supported his election. I'm not saying that was a cause and effect. But anyway, if we can do in-person meetings on a quarterly basis, you'd get a lot more input from the consumer and family portions of our user base. And I think that's important. You just started doing it once a year, apparently. I think there was a whole lot more input gained from that. I certainly gathered more, having attended that. I got this little bumper sticker here. I heard people say, how can we get people to know about 988? Well, maybe you can do this with it. Or you can put it on your, but that's where they came from. They came from that in-person meeting. So I would encourage consideration of in-person meetings. You get a lot more opportunity to interact and really find out how people are feeling about how the services are being put into place. Thanks, and thanks again for being there.
Thank you.
Thank you. I'm Rosemary Dempsey. I wanted to thank you also for taking the job, and your perspective and your freshness your enthusiasm is contagious, so thank you. And feel free to make everybody back there at the office responsible for these answers. I just wanted to recognize that there's a long road ahead, and this is a good time to innovate. And I think a couple things that could help is by OMHSAS continuing to be creative, which they have in the past, such as allowing for dual licensure of providers to be both mental health and drug and alcohol licensed at the same time. Not everyone will raise their hand to do that. I also agree with Dr. Jones, and which Val seconded all third, that the delivery system for the past 25 years has internalized the need to not do anything about people without them. And that language, not specifically, is embedded in all of our contracts, the contracts between the counties and the joinders with OMHSAS and DHS, the contracts with the MCOs and the Office of Long-Term Living and the Office of Medical Assistance Programs. And in turn, the contracts that the MCOs have go to the providers and embed that same language. So when we don't hear that information about and the inclusivity of people with lived experience kind of inundating, informing policy at the local county levels, mental health planning and ID counseling, like Dr. Jones was talking about, or at the state level. When we don't hear that, that's when we really start thinking even our state level contracts, or even our state level staff have gotten so kind of encumbered with what they're being asked to do with HR1, they've forgotten the basics that we've been living under for so long. And so it feels a little bit like, hey, where did all our principles go? Pennsylvania is one of the last, if not of only a couple carve-out states. And we have a very rich behavioral health system that we've spent a lot of time and energy, invested a lot of money in developing, and I think it's the best in the country. I think that we need to protect it. And the way to protect it is what we've talked about today, is by organizing ourselves as a community. And I would love to see the state embrace, and I know this is tricky, embrace all of the energy here and across the state of the behavioral health provider delivery system and all the advocacy, and mobilize us. Let us be part of the solution. I'd seen Secretary Arkush kind of speak to the representatives during the DHS budget hearing, and she was clearly trying to let them know, you know, there's going to be a problem here. And they, in turn, were asking her, what are you going to do about this problem? And so I think each other thinks that someone else is responsible for the solution. But I think we are here saying we want to be part of the solution. And this is difficult because you guys are a rock in a hard place with the feds saying, do this, do this, do this, cut this. You're looking at a huge budget loss. How are we going to sustain? Maybe it'll be overturned. What do we do now? Should we, what's our state of affairs? And yet you're coming to meetings like this and having people say, let us help. But sometimes it feels like a complaint. So I want to tell you that while it may be sounding like a complaint, we are, I think, are ready to organize to operationalize love, for lack of a better word, for the people we've been invested in for so many years. So sorry, I'm verbose, but
No, thank you so much
thanks.
for those comments. And I think it's so important that everyone wants to come together. I think, you know, we see that we collectively, right, see that there's a problem, and no one person or one organization is going to be able to solve it. So it's really imperative upon us to work together.
Eileen, can I point out your, it might be, I don't know if Julia knows about.
She does.
She does, okay.
Yeah.
You've already had a chance to talk.
We've been on a Zoom call. See that?
Okay.
Yes.
Okay, I'm going to go back, James, then.
Hi, I'm James. I'm from Philadelphia. I'll keep this really short, but I think, particularly talking about the state hospital system, I feel like a voice that's not often in the room is the judicial branch, because that's who gets people in, and that's often who's creating a bottleneck. So it's just something to put on the radar, because by the time somebody's going to be at the state hospital for a period of time, like, the judges will have some concerns that are usually well-intentioned, but maybe they're not realizing their role in creating these bottlenecks. And most of what I do in private practice as a forensic psychologist is mostly in the criminal justice system,
Yeah.
but trying to think about the workarounds for somebody being in some type of an institution, whether or not it's a state hospital or in a jail or like a prison facility. So just to your earlier point and to all the points about siloing, I feel like as much as the executive branch can do a lot of things, they don't have complete control over it because of the judiciary. So I'm just wondering if there's ways to kind of like, and because I see this in local politics in Philadelphia too, is there a way to tie those things together a little bit better so that when OMHSAS does a lot of great things, that it's not undermined by individuals who might not be completely behaviorally health informed?
I think one small piece of that, part of the new position that was created, the logistics and patient flow, that's going to include those individuals coming into our forensic state hospital. So that is both for forensic and civil, because yes, there's certainly a bottleneck there as well. And then also I think us being more creative. I think, Rosemary, you were talking about, how can we be creative? Thinking about like outpatient competency restoration. Where does that lie, right? Or non-state hospital-based restoration services, where do those lie, right? And so again, I think it really is going to involve all of us talking together. And it's not just like an OMHSAS directive, but also like where do the counties come in? Where do the providers come in, right? We all are kind of in this together. But I really appreciate you highlighting the forensic and the legal portion that very much impacts us.
Thank you. So I have a quick question relative to the RHTP. And there was a recent request for people's interest in either being an expert in their content for an advisory council or for participating in the RCCs. And just wondering if you have a time frame for when those announcements will be made for those that have put their name in the hat.
I do not know.
Okay.
I'm sorry.
That's okay. Hope it's soon.
Yes, unfortunately, I don't think Julie has the control over how they're choosing people or the quick announcement that went out, which we were not totally a fan of. That's not your fault, though. But who am I going to first? Oh, Dr. Jones.
I did want to just follow up on the forensic, the competency, mental health court diversion. I moved here from Florida most recently, which of course is a state well known for its kind of criminal legal system reforms and diversion mechanisms. In my department was the host to the Mental Health Criminal Justice TA and Technical Assistance Center for Florida.
Is that the Miami
So
model?
no. Well,
Okay.
we worked closely with everyone across
Okay.
the state. So it's a statewide training and
okay.
technical assistance. It was based at the University of South Florida. And among other things, they would do we would do monthly convenings to bring together every county to really discuss, to share learning from largely a lot of diversion mechanisms, but also reentry stuff. And really also created a mechanism for pulling in stakeholders and making sure that direct stakeholder voices and perspectives were represented. Without those kind of TA mechanisms, what one ends up with is such a degree of decentralization and siloing, as in Pennsylvania, that there is no mechanism for shared learning between counties. And there is so one thing the center would also do is provide trainings, for instance, free trainings and train the trainer trainings in sequential intercept mapping and trauma-informed criminal justice responses and on and on. So you create a focus point, right, for best practices, for training, for development, and for the growth that comes from sharing between counties. What is happening here, I'm sure most people read like the Spotlight PA, kind of deep dive expose journalistic piece that featured our lovely county Allegheny, and it's really horrific what happens to people. It's completely unacceptable that there is not more robust community-based competency restoration for absolutely minor criminal charges. And, I think it also, like, speaking to earlier comments about advocacy, when everybody is so divided across county lines, because all there is this little tiny siloed bubbles, it makes it, again, really hard for there to be that collective push for the kinds of systems reforms that actually we see in many other states. Florida's deep red, right, at this point, right? And they're doing it, and yet we here in Pennsylvania don't actually have that kind of investment. So I just wanted to suggest that, and I still haven't quite figured out, although I've had some very helpful conversations here, why we have such incredibly limited statewide training and technical assistance for best practices in any number of areas. That is an absolutely established evidence-based way, right, to really spread best practices, to create ongoing kind of sources of continuing education and implementation supports. And I want to put that out because to me, I guess I'm not willing to give up on the possibility that that could really happen in Pennsylvania in a bigger way. I think it's really, really critical, actually, that that be pursued. And there's areas in which one can almost do like sort of a SWOT analysis and think about where are there the biggest gaps in Pennsylvania system of care. And I do think diversion and criminal legal side kind of crossover is one of them from my perspective. And that's where you need these strong training and TA mechanisms. Ken and I were discussing this in the car, but it's great that the public psychiatry fellowships exist. But the backbone of all of these services are actually social workers, paraprofessional providers, right, at the bachelor's level, counselors, nurses, right? And so there needs to be a place that really kind of fuels the training of those folks and inspires people to want to stay in what is, perennially undercompensated kind of work, right? So like giving them that extra inspiration, resourcing training. So I just wanted to put it out there, and I know you're very new to it. It is a bit of a mystery to me why we don't. We have it in a few areas. There's Heads Up on the early psychosis side. Penn, the University of Pennsylvania, right, gets some amount of money for mental health services research. I can't quite figure out, from the state, I can't quite figure out what that goes to, but it's not a completely non-existent thing, but it's very underdeveloped. So I'm just curious your thoughts, and or just to say it would be really wonderful to see this happen. I bet there's tons of ideas from people in the room as to what could kind of constitute these kind of training and technical assistance initiatives.
Yeah, I think it's a really important component when you think about mental health care delivery and keeping people up to date with evidence-based practices and also keeping people engaged in their work. I'm gonna pull the 6-month card and just say that I don't know enough about what actually is there, but I think it's a really important point that you bring up and something that I'll bring back to our team.
So Julie, just to add to that, lots of hands. So when we're talking about the diversion, you have some really good experts, even in this room. You have Dr. Fairfax Colombo, you've got Dr. Michelle Bertina, who's online. So you do have people here who know of models and how to get this done. And to the workforce, the training and development, we have some models for that too. We have things that are happening all over the state. So, I know I always say use this as a resource, but use this as a resource because we really do have a good collective knowledge of how to make some of these things work, at least on a local level. And I'm sure people would be more than happy to talk with anyone at OMHSAS about how to make that a reality at a state level.
Thank you.
Since this is my first meeting and I'm new to this organization, after you have these amazing, powerful twice-a-year meetings, then you have the weekly discussions. Like, what happens to all of the great ideas? And do people divvy up into work groups? Like, where does it all go? Where does all the energy go? I'm just trying to understand. Who directs it? Who keeps people on target? I've got this great idea. What do I do with this? How do you move it forward?
I'm going to pull a 20-year card. I've been doing this long enough. I give it to Val. We do meet every Thursday from 6 until 7 o'clock, and we discuss ways that we can pursue some of the ideas that are brought up here. So Julie we will be talking with Julie again, hopefully before the next 6 months, in order to have a conversation about some of the things that we've discussed here and to identify and follow up on ideas that we've identified here. There are like 15 hands up in front of me here, and I recognize that we're supposed to start in a few moments, and I'm going to pass this to Val to give to everybody. I did want to say one other thing in addition, because we're going to have to follow up on this, and that is there was a recent National Academy of Science, Engineering, and Medicine committee meeting on the use of graduate medical education as a way to meet the issues of accessibility of care for Americans. And the basic idea was you have to train people to work in community settings where the people need to be seen.
Yeah.
And so part of the thinking there is we need to develop residency programs and develop methods of enticing people to stay after residency programs in the state. Now, I don't want to pass up on Nev's point. It isn't just the psychiatrists that are important in this.
Right.
Although what we do know is that if you train a psychiatrist and you place them, then you have to have social work and all the other parts. So we need the whole team built, and we need the primary health services on the medical side as well to make that connection. But that requires the state to be aggressively active in this process of ensuring that there are doctors being trained in settings that will keep them in the state. And that's what the PPLC is about. And it would be nice to feel some love from the state in that work, because we do this work now without any state support. And that's not the way historically it had been. And we feel that in this moment, where there's a real need to make sure that we continue to bring good, young psychiatrists into practice and support those folks who are already there, that it would be a waste of a good resource not to continue to promote the ongoing support of those folks. And then lastly, I'll just say it relative to Nev's point about methods of promoting best practice and technical assistance and things like that. We used to have at the state level 2 programs that did that. And unfortunately, they both basically folded as far as I can tell. I don't know exactly what's happened, but I don't run into them. They folded when medicine was corporatized. So the University of Pittsburgh had a whole program of education and technical support and activity throughout Western Pennsylvania, and was called ORP. It doesn't exist anymore, or if it exists, it only serves UPMC entities. It doesn't actually serve all the enterprises in the western part of the state. So there is a history here of developing and supporting that kind of thing, but it can't be in the universities in the way that they used to be, unfortunately. And it could be maybe an independent organization. I'm done.
Hi, Julie. I wanted to go back to your question about AI and the use of it. So, number
probably a
one,
whole
I'll be
other
brief.
hour.
I'll be brief. Number one, I think looking at workflows, psychiatric workflow is important. I do know that at Penn State there was a doctor who was in primary care, and he was doing some research on this and figuring out how overwhelmed we get with our inboxes. And he said that there's certain places, I believe in Allentown or so forth, that they use these virtual physician kind of store places to kind of answer these questions that are very common for our patients. So like an FAQ one. So that was one. Number 2 would be looking at AI for brief interventions, be it like smoking, for behavioral activation and depression. So looking at brief interventions that you could really get a GPT and really go into it and make sure that it doesn't go outside the parameters. So it's really giving how to do certain things versus giving more therapy kind of use. I think it can be used in therapy, but as an adjunctive with a therapist overseeing it, but not outside of that. I would be kind of fearful to do that. So those are like 2 ways that I think it could be well placed and used. The other thing I see also is, I believe, I'm not sure if it's still, just because of my thought process here, is that I think it's being used by certain companies for prior authorizations, just because sometimes it doesn't read fine print, and we have to send it back again or talk to a real human and let them know, hey, this is occurring. We actually gave you this information. Somehow it's not reading it correctly. So I think 2 systems might be clashing together. Thanks.
So I really kind of wanted to go to your question on how we coordinate and across systems. I think it's important to remember Florida is a state, it's state down. Pennsylvania is state supervision, county control. So how we have to look at these things, so the state's role would be to create minimum regulations, but you would have to have regulations across all of those different silos that would help do that, coordinate those services that you're talking about, or have some sort of agreement between them. If you understand that it's not quite as simple as the state says, yada, 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 and everybody has to fall into place. That's not how it's kind of going to happen here, unless the legislature creates legislation and it passes. And there is that. But I think it could be done. It's just how you would go about it would look different here than it does. And there's only a few of us states left that do it that way. I think there's 8 states total. California would be one that it makes it a little bit more complicated when you're only state supervised and the control is below you, so to speak. So Massachusetts, Pennsylvania, Kentucky, yeah, Virginia's kinda, yeah. But there's 8 states. So we function that way, and when we think about making change, it's important to remember how we would do that. It may not be as a direct route as we would like, but it can happen.
Just to respond quickly to that, I think a training NTA mechanism has had no authority whatsoever. It's merely a mechanism to train people. So when the state of Florida created the Mental Health Criminal Justice Center, it's not with any authority in a top-down way. It's to create a mechanism, which is very, very common, I think, across the U.S., regardless of the structure of states. There has to be just enough money or will to fund a center like that. But it's not that they have regulatory authority or anything like that. So.
They may create it, but they're not going to fund it at this point in time. So, you can get it done. How you can do it might take a little.
Plus you need an agency who's designated to be able to do authority and do guidance, and we can't.
Well, yeah, it doesn't have to be authority. It's literally just training and best practices. Well, yeah, for some issues, and that's my point is that it doesn't exist at all for some issues. It doesn't equitably cover the state for some issues, right? And so it's a well-established evidence-based mechanism for supporting quality improvement and innovation. Nothing about the structure of the state of Pennsylvania prevents it from happening, but there would have to be a political will behind it. Yeah, yeah.
That's really it. So it can be done. It's just how you do it might be.
Yeah, no, it clearly things look like there's a lot of challenges here. There's 100%.
Thank you. And maybe expanding upon looking into the technical assistance issue, that structures that are already out there, maybe that's something to think about building on. I'm so sorry we didn't get to the AI.
It's okay. This was very productive.
I'm going to
Thank
make
you.
an offer. If you and Secretary Smith would like to have a special time to meet with this group, we could certainly set that up.
Yeah.
Let
That'd
us
be
know.
great.
Yeah, I'm assuming that would be okay with everybody. We'd do it virtually. We wouldn't all drive to Harrisburg. We could do that online. But we could sort of do a special meeting where we could be talking specifically about AI so that we could give you feedback. You could ask questions. Would that work for
I would love
folks?
that.
Okay, perfect. All right, well, we're going to take a very short, and I mean short, I mean like 3-minute break while we get our last speakers up. I want to just thank Dr. Julie Graziani again for joining us. She's only been here 6 months. She's doing a great job. Thank you so much, Julie.
Thank you.
Tells me that the 3 minutes are about up.
Go ahead, let them know, Stan.
I guess they're up now. Val is coming to take charge.
Okay, you had more than 3 minutes. You had more.
I'm going to start.
I feel like we're about to sing a duet. I probably could. Okay, so I should technically introduce. I probably should start there. So, happy 250th of the United States. When we were planning our spring conference this year, Ken was talking a lot about history, and I knew that Stan had just done some history work with NAMI for a grant that they were doing. And we thought, wouldn't it be nice if they could team up on something that could talk about the history of mental health in Pennsylvania that has a very rich history. So I introduce Stan Marzowski and Ken Thompson.
In doing a little bit of the research for this, I was struck by how interest in mental health has been part of our nation even before you had a country. And so we're going to talk today a little bit about actually more than 250 years, if you can believe that. But not only where have we been, what Ken really wants to help us do is a bit of a dialogue, which in a way is going to be picking up on what we were just doing about where, not only where have we been, but where are we going. All right, next slide. I have the clicker. And I must be going the wrong way. No, that's the pointer. So as I said, a little more than 250 years ago, because in 1751, the Pennsylvania legislature established a hospital in Philadelphia to care for the sick, poor, and insane who were wandering the streets of Philadelphia. Important thing here, not only was it a long time ago, again, before 1776, but it was an integrated approach. It was for people who were ill and people who had mental health challenges. Dr. Thomas Bond, a physician, got his friend Benjamin Franklin, who organized a petition, got 2,000 people. Now, there weren't a lot of people. I'm thinking there were maybe 25,000 people in the greater Philadelphia area at that time. A lot of them signed this petition, and not only that, Franklin was able to raise money to establish this hospital in Philadelphia. Franklin has been quoted as saying it was one of the more gratifying things that he'd ever done in his career, and if you know anything about him, that's saying a lot. Another important figure, Benjamin Rush, one of the most prestigious physicians in colonial America, a social reformer, an advocate for prison reform, abolition of slavery, education for women, common schools for children, a signer of the Declaration of Independence, an advocate of separation from England, pointing out that psychiatrists and the rest of us in behavioral health have a role in the kind of society in which we live, in the kind of society in which our mental health is. Rush, first physician to in what to become the United States, to look at mental health and issues around mental health. 50-some years after Pennsylvania Hospital, the Friends Asylum was open, and it was the first hospital specifically to care using this moral treatment philosophy. Now, those of you who have been to Williamsburg, Virginia, will maybe remember or know about the first dedicated hospital for mental health that was in Williamsburg. But the first one that was first hospital in the colonies, and then this first hospital that used the moral treatment approach was the Quaker, the Friends Hospital. This moral treatment approach became a standard. In the 1800s, the hospitals that had been established, were being established, became crowded with a lot of challenges, including those who had mental health challenges. So new facilities were starting to be developed, and in Philadelphia, the Institute of Pennsylvania Hospital opened in 1851. Now, why this is important is because it was sort of the forerunner of the state hospital system, but also this guy named Thomas Kirkbride was the leader of this first institution here, and was an advocate of this moral treatment approach, believed that patients should be treated with kindness and sympathetic care, encouraged the use of the term hospital, discouraged the use of the terms asylum and insane. Something that we can still remember and maybe try to practice. The Kirkbride plan became quite famous for the way that hospitals were structured and laid out, not only in Pennsylvania, but across the country. Natural light, ventilation, therapeutic environments. Kirkbride not only did that, but in 1844, he brought together a group of superintendents from hospitals across what were then the colony, early part of the United States, and led to the creation of what is now known as the American Psychiatric Association. So the role of Pennsylvania in development of mental health has been a critical central one. Now we're going to try to play this video because it captures in a very nice way the role of the state hospitals, the first one in this area, in the Harrisburg area, 1851, with the Harrisburg State Hospital, which not only isn't the state hospital anymore, but practically doesn't exist. I think all of the buildings are gone, with the exception maybe the administration building, which is on the National Registry. So let's try the video. Video that was produced by the Department of Human Services a couple of years ago to present some of the history of the state hospital system and take us through the sort of the highs and then the lows and then how we developed from that. Hopefully we can get the sound and not just video because the pictures aren't. Okay, we were maybe fearful that this might happen. For those of you who earlier saw the challenges. Well, what he was saying is that there needs to be some special cable that he thinks need to be done. And we're probably not going to do it. So I'm going to wing it. I would encourage you, it's an 8-minute video. Teresa Miller was the Secretary of the Department of Human Services at that time. Dan Eisenhower, who was the administrator for the Dauphin County Mental Health Intellectual Disabilities Program. This was Sue Walther. Some of you remember her. A professor, was that at Temple? Thomas Downey. It's a very well put together review of the state hospital system of Pennsylvania, how it was intended, how it worked well.
Harrisburg State Hospital was built to be a self-sustaining community. They had a farm. They expected the residents or patients to be working on the farm, to have a productive day, to have staff support. And then the state hospital system in Pennsylvania grew from the original Harrisburg State Hospital throughout the rest of the 1800s and early 1900s to about 24 state hospitals.
If you have 5,000 people in the same institutional setting, how do you simply manage adequate care? It proves to be impossible near the controversies of the late 20th century. Bad things happen.
When you look at the history of some of the state institutions, horrible things were done. Because that's the nature of an institution. When there's one group totally in control and another group doesn't have any control at all, bad things happen. Philadelphia State Hospital Library is a perfect example of that.
End upon end of beds with shackles where people are just handcuffed to the bed so they can't roam around. The use of isolation, the use of cages, being handcuffed as a form of not only treatment but punishment, sometimes to run for days. It's hard to justify that as a moral or even a rational basis of treatment for someone who has a cognitive or mental disability. In terms of treatment, by the 1930s, there was both a kind of ethos of compassionate or humanitarian concern and seeing mental health issues as a problem of disease of the mind.
But it was the late 40s and early 50s when there were some breakthroughs. Thorazine became known to be an effective antipsychotic, and lithium became available to treat people with manic depressive disorders, also in the early 1950s. So for the first time, there were options available from a medication perspective.
We really started to see a decline in people being served in state hospitals in the late 1950s. And in the 60s and the 70s, we had, of course, the civil rights movement where we saw large groups that were formerly not really in the mainstream really move more into mainstream society.
But the groundbreaking change was in 1963. President then Kennedy signed into law a National Community Mental Health Act in 1963, which started to create the foundation for a community-based mental health system. And then Pennsylvania passed legislation in 1966 called the MHID Act of 1966, which established a state-funded, county-operated system of community-based care for people with mental health disorders and people with intellectual disabilities. So those things were groundbreaking because it was literally the first time that Pennsylvania started to fund a community-based system as an alternative to institutions. And so that push began the push to deinstitutionalize people.
In the 1980s, because of the public uproar over institutions, we began to see a concerted effort to move people who can be moved back into the community. And that's kind of the most recent phase in a long history of evolution. The notion with the proper supports, the proper services, the proper supervision, people may be able to leave institutions and live more independent lives. It's not only a medical decision, it also comes to be seen as a civil rights decision, the right to freedom, the right to liberty.
In the 1990s, early 1990s, they started a dedicated funding stream called CHIP, with two P's, Community Hospital Integration Program Project, which was a program where the state provided additional funding to counties to close state hospital beds and then use those funds to develop community-based services and supports. And then there was also the Olmstead Act in 1999, which the Supreme Court ruled that people should be given a community alternative as opposed to institutional care. So basically, people shouldn't be kept in institutions simply because of a lack of funding.
Today, we have less than 1,600 people being served in state hospitals. So we went from about 25 hospitals owned by the state at one point to today, we've got 6.
It's difficult to, at some point, justify having these large institutions that are costly. I mean, these are white elephants at this point. These were built a long time ago. They have a lot of cost associated with them.
We are getting ready this year to close Norristown State Hospital's civil unit. Understand that community living is the best option for a lot of folks, and if we can serve people in the community where they're surrounded by kind of their natural community supports, their family and friends, that's going to be better for individuals than being isolated in an institutional setting. We've been in a time of change, and we continue to be in a time of change. You know, for our state hospitals, the Olmstead decision means we have to make sure that we are serving people in the least restrictive setting, and that we're doing more community integration than we've done historically. And from DHS's perspective, that's absolutely the right thing to do. We're embracing that, but it definitely is a time of change.
thanks to our hardworking tech people for that video, which I think captures, and I think it was an 8-minute video, the essence of what we tried to do in this Commonwealth with state hospitals, what the problems were, where we're trying to go now. You don't want to look at me, you want to look back at our slides. There we go. So as was referenced, the Community Mental Health Act of 1963, federal legislation, the first time that the federal government said there's an obligation on the part of the federal government to help with community mental health and intellectual disabilities. The challenge was that I believe there were projected 1,500 community mental health centers to be established nationwide. Less than half of those were ever funded, and even the ones that were funded, the funding was inadequate and eventually fell way below what was absolutely needed. States began to pick up, as it was again in the video, the 1966 law in Pennsylvania to get the communities, the counties, much more involved. Typically, for most of the most of the mental health funding, there's a 90-10. 90% of it comes from the state. The counties match 10%. In the 1990s, Health Choices was established. Managed Medicaid began for both health and behavioral health. There's been, again, now this nearly 30-year history of expanding locally identified behavioral health services through Health Choices. So we have a long history of trying to do the right thing, of struggling with some of these issues. And in a very concise way, we can say that what we have is an inadequate system. Many communities, I would say probably all communities in Pennsylvania, lack enough resources for preventative care, for healing. Clinical services are stretched beyond capacity. Workforce issues abound. Traditional interventions are fragmented, underfinanced, often overwhelmed. Even when they function well, the traditional services, the services that most people come to know of as mental health services, don't address root causes that are especially entrenched in social determinants. And our informal support systems are under-resourced and unable to bridge the gaps between the formal systems and the informal systems. We looked at PPLC, we looked at, what we did was we developed a paper called Reimagining the Mental Health System. And Julie, I believe we've sent that to you. If not, we'll send it again. But one of the things we did was we looked at what's the world looking at here? What are other countries doing? In addition, what are other states doing in this country? The World Health Organization identified 3 very important kind of fundamental pillars here. We need to deepen the value and commitment to mental health. I had earlier said that has been an interest in mental health right from the very beginnings of this country. It still remains, stigma, it's not well understood, not well documented, but all of us human beings have issues and interests in our own mental health as well as that of our friends and families. We need to deepen that commitment. We need to capitalize more on that. We need to reshape the environments that influence mental health. Homes, communities, workplaces, schools, healthcare services. And we need to strengthen mental health care by changing how and by whom it's delivered. It's not just psychiatrists. Yeah, you folks are really important, no question. And it's not just social workers, but mental health care can be delivered by a wide range. We're learning that very effectively with the work of peers. So with that quick jaunt through history, I'm now going to ask Ken to lead us through some questions and a discussion.
Thank you, Stan. This particular conversation was inspired by the fact that we have the 250th anniversary of the country coming up in July. And to be honest with you, for a variety of reasons, which are probably not I don't need to explain. My enthusiasm for this upcoming birthday has been somewhat dampened. I just don't feel it. I mean, and I kind of remember, some folks in the room might remember 1976 and the tall ships and various other things that were kind of a celebration. There was a little bit of a sense of a celebration. It was 200 years. So I was kind of feeling gloomy about this. You know, this is like 250 years. You don't get to have 50th anniversaries of the United States all that many times in your life. It seemed like it should be something to be excited about and something to celebrate. And then it occurred to me that I don't have to wait for the federal government, for example, to do the things that I need to do to celebrate this fact, and that in fact, in the work I do and in the people that I'm with, maybe what we could do is to begin to imagine what this 250th anniversary actually could mean, and to think about it as an opportunity to actually dream again a little bit and to imagine a future that we care about. So one thing I've kind of come to terms with, and this has actually been over the last day, it really strikes me personally that the people of the United States not only deserve to have extraordinarily good psychiatric and mental health care, not only do they deserve to have a really good healthcare system that's universal and accessible to all. Not only do we deserve to have good communities to live in and decent jobs, the truth of the matter is we've earned all those things. We've actually earned all those things. And the folks who right now who are sitting on top of very large piles of money and who are not in any way contributing to the tasks that I just outlined of what it is that we deserve and what we've earned. It's time for us, I think, to begin to understand the true nature of the American Revolution and the idea that it is an ongoing revolution, and it is a revolution in which we all have to participate. We don't get to choose our times, we just get to choose what we do in them. And at this moment, I think it's really clear from all the things we've talked about today, all the things that just got outlined by Stan, that that what we need for Pennsylvania and for the country is a very different way of thinking about how we fund and operate and who provides the services and how they're provided and when they're provided, that it is actually this little part of the world, America's psyche, America's mental health, is deserving and has in fact earned a new way of being and a new way of doing. So some of the questions, is there a way to go back to the questions I had up there? Do you have this stick? Oh, they're up, okay. So the issues that we need to start thinking about are, what are the problems? What kinds of problems do we face? And what kind of institutions do we need to create? What kind of institutions do we need to revise? How are we going to deal with the fact that we will never, ever be able to meet all of the needs with the limited resources we have unless we begin to think differently about what kind of resources we have and how we're going to address the needs, and unless we can figure out how to reduce the number of people who are coming forward who've been injured, wounded, and are suffering because of psychic and physical casualty injuries. How are the states and the federal roles going to evolve over time? And what do we do in our society now to begin this revolution of rethinking what it is we do and how we do it. I think, you know, we've heard today, I think Father Paul said it, that what was before is what was before. And that this moment, if I heard him right, and if I actually attuned to my own intuitions, the era that we were living in before is not an era we are going to go back to. We're not going back to where we were. We really do have to figure out where we're going to go forward. That's my opinion. I don't know if other people feel that way. I don't think that the way I had approached the era that we're living in my mind until relatively recently was that this was just some strange aberration in American history. I don't think it's just a strange aberration in American history. It is, in fact, a culmination of many things that have gone on for a long time and that we now are called on to find a resolution to move beyond where it has taken us. And I think in the world of mental health, that is really going to mean that we are thinking about things differently. As I said, I believe we've earned as a people the right to be taken care of, to have health care, to have a minimum standard of decent living in communities with libraries and opportunities for work and play and families. I believe we've earned those things. It's not just that we deserve them, we've earned them. And we need to decide how we are going to get them. We have to just decide that. The last thing I want to say about this, and I would love to hear people's comments, is, and this is a hobby horse that I've ridden. Val knows what I'm going to talk about in terms of the Pennsylvania State Constitution. We talked about it a little last night. If you look at the Pennsylvania State Constitution, since we're focused right now at what's happening at the state level, the Pennsylvania State Constitution does not have a general welfare clause in it. It is a state constitution that's built on property rights, a little bit about your rights as citizens, but mostly it's about who gets to own property and what are the processes of government. There is nothing in there that says that our government has any duty to work to ensure that the people of Pennsylvania flourish. The only people who are going to make Pennsylvania flourish are Pennsylvanians. We have to figure out how to work with our government to make that something that they understand is clear, because I don't think they think that way right now, and it's not in their remit. So that's part of the revolution is, in order for us to be a community, we actually have to decide that we want to be a community and that we want to flourish as a community. And that we want all the parts of our community to work towards that for everybody. That's my little pitch here. Mental health in Pennsylvania, which is really another word for the well-being of people in Pennsylvania, has long been a concern of Pennsylvania. We've been leaders in that area. I wonder how we can lead into the future. Is there any way we can catch up with the work of Benjamin Rush, Benjamin Franklin, Dorothea Dix and her work with the Harrisburg State Hospital, which, by the way, the acronym HSH, anybody want to guess what that meant to the people of this hospital in Harrisburg State Hospital? HSH? Home Sweet Home. That's what they called it. Now I'd like to see the whole state be a home sweet home. Anybody have any thoughts? Allison. Thank you.
I guess in terms of aspirations, one of the things I think about a lot is our system being, somebody in need being able to walk in to a place where they can be seen, heard, felt like their issues matter, and that can sort of flexibly evaluate and hopefully address a range of issues from mental, a mental health condition to substance use conditions, but also to be able to address health-related social needs at the same time, which we know are so intertwined with both mental health and substance use conditions. And I guess I see, we're developing this crisis side of the system, which is absolutely needed. But I don't have a sense that and I think we used this as a theme in a previous conference. I don't have a sense that we have anything meaningful to connect it to once people sort of enter the crisis system. I practice locally in the Harrisburg area and see people from Dauphin, Cumberland, Perry counties. And we are fortunate in our area that our counties got a grant to build a brand new crisis walk-in center. So we now have that resource available, but they literally do not have any providers in the community who are willing to directly accept referrals of people who are being seen there for outpatient care, right? If people need inpatient or rehab, they'll work to get them there. But speaking with one of the nurses who was employed there, patients who are being seen there are being handed a paper list of places to call. So I guess that's sort of my vision, is really having a place where people could walk in their moment of need when they're ready to get connected to something, they're open to it, and actually have those connections made flexibly, sort of adapting to where they are at that moment. And I know that there are, there's the CCBHC model, the Certified Behavioral Health Center model, which incorporates a lot of these elements, but which Pennsylvania has not in any way adopted.
Wait, there's comments over here.
It's interesting because there are different levels at which this can be looked at. Ken said that we need to think about things differently. Absolutely. But it's more than an operational issue. The question of how to organize our funds, how to distribute care, essential. But there's something fundamentally missing in the minds of too many Americans, which is to say that they and we have a right to this, that this is a right, an entitlement. You talked about it being earned. We've earned it. We pay for it in terms of our taxes. Whether or not the Pennsylvania Constitution states this or not, overall, there is a social contract here. But people don't see that. They see accepting benefits in some way as selfish and a surrender. And this is very different in Europe. Somehow, and I don't see this as easy, at the same time that we deal with the operational issues, we have to try to change the mindset of people to see that this is something fundamental that they do deserve, and that it is the responsibility of our society to provide.
Thank you, Gordon. So listen, there's just no way that you can't come back to these meetings in the future. I mean, you can't contribute like that and then drop the mic and walk out the door. So I'll just say that. But I say that in love, and that actually is a good jumping off point to what I wanted to actually follow up on what your comment was. I think this is what Father Paul was talking about. Our idea that our country is made up of people who are paying taxes. When I say that we have earned it, I don't mean just that we have paid taxes. We have created relationships and families and communities and all kinds of connections and exquisitely beautiful things and some things that are just patchwork to get by. We've done all those things, not all the time with money, oftentimes without any money at all, and without money going to the state. The state is not the country. The state is part of the country. But the state and the country has earned, in all the things we've done, not just paying taxes, we've earned and should enforce the fact that we all need to care about each other. And we all need to be contributing as what we can. And we all need to have our gifts identified and allowed to give them. That's what we need to work on and develop. And that ethos, I think, needs to not only be monetized. It has to be. We have to figure out how to create that in the souls of the people who live here, and I don't mean just the citizens, but the people who live here, because if there has been any action in the last 50 years that demonstrates where we can go wrong, it's been in the actions of ICE. It has been in the ripping of people out of the communities. That is as close as I can get to what was happening with Bull Connor, sicking the dogs on the people during the civil rights demonstrations. Those activities were just atrocious, and we're seeing them again here. So how we come to a point where we understand that we are all linked together, connected together by mystic chords of memory. I don't know how we do it, Gordon, but I do think you're right. That is what we need to figure out in addition to the operational aspects of this. The operational aspects, I think, will flow better. That's why I'll say one last thing. I'm sorry you got me revved. That's why it's so painful to me to not have a way to express my feelings about the 250th anniversary and how significant it is that we have a country that can be made better and can be made better by the people. There's some countries right now that people can't budget. They're not in a place to budget. We are in a place to budge our country in the right direction, and we always will be as long as we continue to budget, as we continue to push it. So I'll just stop there. Mary Ann. If you want to say something, take that away from me.
So I really appreciate the conversation around history, and resonates with what the Reverend Paul Abernathy shared with us this morning, and that is that we need to be able to know, understand, remember, and work together to heal and move forward with not just what some people define as our wonderfulness, but what has occurred in the 250 years plus of this nation and how it was built. And it was built on slavery, it was built on immigrants, and we need to address that as we move forward, or we will be stuck in these kinds of repeating systems that do not address any of these things in a way that is equitable, just, and we will engage in othering. So we need to come together in communities and figure this out and be able to put it to words and work at healing.
I guess just piggybacking on that, and also kind of in reference to history, we have never overcome the sort of both kind of epistemic power differentials and just plain old disconnects in perspective understanding between those directly impacted by the system and providers, especially in some sense psychiatrists who have the most formal power within the system over things like civil commitment, medication over objection. A lot of my work just endlessly documents the perceived, lack of understanding, the perceived trauma in the system. A lot of people feel deeply and profoundly traumatized by their experiences of psychiatric services. And it's not a new thing to say. It's something that we still haven't overcome. And I would also just really emphasize the sort of the disability justice principle of including those most impacted, meaning people who have really experienced things like long-term AOT, institutionalization, many repeated involuntary inpatient commitments, people who have been on high doses of antipsychotics for years or decades. That's where we really kind of probably see the most suffering and the most harms, arguably, of the system. And to me, it is a really profound tragedy to not recenter our systems, our design work, our thinking around the people actually being most impacted by it, and taking that as our cue in terms of what needs to change, what we need to reimagine. I think this goes back to slavery, because this is what we have done to people who are othered or marginalized from the origins of this country, and it has actually never changed. I would argue that during the late 70s, 80s, 90s was maybe actually the peak of some kind of starts of a reckoning and reconciliation, and that just seems gone. And in particular, I think folks who really, a lot of people still get institutionalized in this country in one way or another. A lot of people, whether we are talking IMDs, SROs, supervised residential facilities, it is still a lot of people. In some states, it is still state hospitals. It is obviously the criminal legal system. And I think bringing them to the center of the table is long overdue. I would love to see PPLC specifically do that, because we can't expect other people to embrace the neighbor and humanize the other if that can't happen at the core of organizing efforts like this.
Hi, it's Rosemary Dempsey again. When I was trained to be a clinician, I was trained to monitor my countertransference, right? To look at countertransference and to protect myself from getting too emotionally involved. And I was thinking about that as Father Paul was talking today, that for me to say love, or to say that I showed love to somebody, would be very, not professional, right, as a clinician. But what I'm saying is that I think we need to start retraining people. I'm not sure if I imagine they still talk to social workers and things about setting boundaries, but we have to allow room for people to show love and interest and concern, and retrain people that they don't have to protect themselves so much. And maybe the burnout would go down if people weren't trying to work in such a tight box to protect themselves, that it would be okay to enjoy a relationship or some connection with the person you're trying to support, and that you don't have to be robotic and take your notes and finish in 50 minutes. If we could reform the payment system and never let finances interfere with the relationship, that would be wonderful.
It seems to me like we're hearing a lot about the need to continue to work on this definition of community mental health, what community really means, and how we can use communities as a way of embracing and enhancing all of our mental health. So maybe without any more comment, we can end there. Mark.
Yeah, I think one of the things that really strikes me is how Hi, Mark Berger from Pittsburgh. So one of the things that has always struck me about our profession is, in a way, how self-congratulatory we are. And I think what's lacking is humility. I think that lack of humility gets in the way of actually hearing people and truly meeting them where they're at. And so I think one of the things that we need to be is more humble as a system, because I think only then can we change.
It would be our strength, actually. Unless there is another comment, I know we are at past 3 o'clock. And I guess what I would say, you know, we talk about community mental health, we talk about community psychiatry. I would note that in every time we say that, community comes first. Community comes first. Thank you, guys. I appreciate it. And happy birthday, America. You want to sing?
Well, thank you, Ken, and thank you, Stan, for that excellent presentation. And we will be sharing that presentation. So what a wonderful learning tool. I was just sitting there, I had no idea we had that video in our archives. And when we talk about educating people, I think part of this is knowing our past, right? I think we've gotten so complacent in the importance of community services largely because I think the average social worker wouldn't know that past. If I were to show that to a group of students, I think they would be shocked, appalled, and awed, which they should be, because we never need to go back to that. And if we're not careful, we could go back to that. So great resource. Thank you, Stan. So we'll be sharing that all with you. Lucy will be sending out the video and some other things in the coming days. Give her a second. She's got a lot on her plate. It's a busy month. But I did just want to take the time to thank everybody for driving across state, spending time with us. Thank you to all of our presenters. Really appreciated everybody's fantastic comments. A huge thanks to Deb Shoemaker and Lucianne Green for making sure that today went so smoothly. We invite you to join us on Thursdays. The question is, what do we do with all this? We do our best with what we have, which is, you know, a small group of volunteers and people who are willing to take on some of these initiatives. So Thursday night is a great opportunity to keep some of these conversations going. On Monday, we meet and we talk about racial justice and how to make sure we're having a diverse psychiatric workforce within the state of Pennsylvania. And if there's anything else that interests you, we can have that conversation too. So hopefully we'll be having a conversation about AI coming up soon. I know that that's a hot topic for a lot of you as well. So stay tuned. I'll talk with Dr. Graziani about that, about how we could set something like that up. So I hope that if you need anything, you'll please reach out. And thank you again. So we'll see you next time. We'll see you in the spring for our next meeting. Oh no, in the fall. Where am I? What's going on? Anything for the good of the order, Ken?
No, I just want to say thank you all for coming. Thank you to our presenters for presenting, and I hope those of you who've come for the first time will come back, and I hope that those of you who think you're here for the last time will come back. and I want to thank you for all your efforts to do our media. Sir, we appreciate it, and we know it wasn't easy, but we are very appreciative of the opportunity to talk to lots of people across the state, and that wouldn't have happened without you, so thank you.
Yeah.
And Lucy and Deb, thank you guys for making this happen, and of course, to our leader, Val, for making this all go.
All right. Well, thank you so much. All right. Oh. Yes, I did give the shout out, but I will give it a shout out again. Racial Justice Initiative on Monday, general meeting on Thursday. And if you're interested in getting in trouble around Medicaid or Compass or anything else, we're having lots of those discussions, maybe not fully PPLC related, but we're doing a lot of different things in those areas. Or go to Katie, I don't know where she went, her advocacy group, get involved. So, and join NAMI. Don't forget to join NAMI.
We have lots of ways to get you in trouble.
That's right.
I do want to mention, actually, and I don't think we did, that we just ran a residency fair for medical students who are interested in going into psychiatry. We just ran a fair, online fair for medical students interested in going into psychiatry. The goal of this initiative is to bring, we can't quite do it like we used to, but the goal is to bring a very diverse group of medical students into residency in the state of Pennsylvania. And that has required us to work with all the residency programs in the state of Pennsylvania, something that has never been done before. And we put together the fair. I say we, what I mean is Deb and Marianne and Lucy helped, and we got 70 medical students from across the country to participate in the fair, to come to Pennsylvania, and our hope that this would be a diverse group of people was absolutely fulfilled. So I am really, really, really happy about this. It means that we may be able to actually make sure that the face of psychiatry looks like the face of Pennsylvania, and we hope that that this effort will be something that we can continue to pursue, because it is really it's really been an extraordinary thing to participate in and to make happen. So we're really excited.
Okay, thank you. Be safe going home, everyone.
You're right. That's